patient, parents, counseling should be aware of the limitation of the outlines. There are some of the criteria which could differentiate the favorable cases and unfavorable cases. There are lots of cephalometric analysis which can help to identify the horizontal and vertical growth pattern. Horizontal growths are more favorable cases compared with the vertical growths. Upper gonial angle are an average of 50 to 55 degrees and mean lower gonial angle 72 to 75 is ideal for the functional therapy. Sum of the posterior angle is less than 396 is favorable for the functional therapy. These are the some criteria to selection of the functional jaw orthopedic. A study was conducted to identify the cephalometric determination of the successful functional applied therapy. The author concluded that the patient with the small anterior and the posterior facial eye respond better for the functional applied. Also, the smaller and more retruded mandible responds well to the functional therapy. Another study has conducted to predict the mandibular changes in functional jaw orthopedic in class 2 patients. Here, the author conducted that the gonial angle less than 125.5 degree responds favorably to the functional therapy. These authors found that another facial height, anterior facial height and size of the mandible did not improve the prediction of the treatment with line. The study contradicts the previous one. The same author had previously published another study to see the functional jaw would result in unfavorable cases. After studying the surgical correction of the class 2 retruded mandible with the high mandibular plane angle, they observed that it was significantly relapsed after surgery. So to perform the functional jaw orthopedic even in an unfavorable skeletal pattern, 2 out of 3 achieve the correction of the disharmony of the occlusion. 1 out of 3 patients require subsequent surgery, but the quantum of the surgery was reduced, and therefore the stability of the post-surgical treatment is improved. So, with informed the consent, even in unfavorable cases, the functional jaw treatment should be attempted. Finally, Jaiswal, increase the lower facial height and vertical grower. Let us look at the vertical grower cases in we achieve the good result with the treatment of therapy. This is a 10 years old girl presented with our office of the chief complaint of the forward place upper incisor incompetently. On extraoral examination, we found the backward rotation of the mandible, increased the anterior facial arc, girl with leg, protruding incisor, and almost 10 to 12 millimeter of interlabial gap. On intraoral examination, it was a mixed dentition. Increase the overjet almost 10 millimeter, angle class 2 molar relationship, class 2 canine relationship, mild crowding in the upper and the lower anterior region. On cephalometric analysis, we found the skeletal class 2 pattern, vertical growth pattern, and the basal angle was 33, which is on average grower, it should be a 25 degree. CVMI stage was between the 3 and 4. See the basal angle and the CVMI test. This is a pre-operative OPG. So the line of treatment was to advance the mandible, do the fixed mechanotherapy, with extraction of the first premolar teeth. This is the tree block outline designed for the finale. See how the head of the condyle will travel from the glenoid fossa to downward and forward over the articular eminence as soon as we insert the twin block. See how the head of the condyle is seated in the normal case, and as soon as we put the twin block applies, how the head of the condyle will travel over the articular eminence. See, these are the picture with having a twin block. If you say VTO is negative, TBA help to improve the paraoral musculature and to hold the mandible. And secondly, vertical growers, we do not advise for a trimming of the twin block to avoid the worsen of the vertical growth. After the twin block therapy, we achieve the superclass molar relationship on the both the side. Overjet and overbite is the relative. Look at how the lower incisor come in enamel to enamel contact. By the end of the twin block therapy, we converted the class 2 dentition into the bimaxillary case. Lip competency is established, though there is a gummy smile, but she is able to close the lip. And at the end of the treatment, if you see the OPT, again the head of the condyle is reseated into the glenoid fossa valve. These are the comparison of the pre and post treatment cephalogram. You can see there is an increase in the retropharyngeal airway also. We have removed the first premolar teeth for a mechanotherapy. Space is closed, appliance is removed. Look at the molar relationship, canine class 1, overjet overbite is established, and see how excellent interdigitation in the posterior segment. This is immediately after removing the fixed appliance. The nasolabial angle is still little compromised, but mainly due to the size and shape of the nose. The profile is perfectly straight. Gingival display on the smile is also adequate as her age. After the 7 years of the follow-up, third molar is erupted in both the upper as well as the lower. Class 1 molar relationship and the well interdigitation is maintained. Overjet and overbite is also perfectly maintained. Canine class 1 relationship is perfectly seated into the lower range. No fixed appliance is given at all. This is how she look after the 7 years of the post-treatment. These are the comparison of the post-treatment before treatment, immediately after removing the appliance, and after the 7 years of the post-treatment follow-up without the fixed retention. These are the pre-treatment, post-treatment, and 7 years follow-up comparison. These are the photographic comparison. If she would have handwritten, we do not think she would have gained the confidence and the personality as we see the today. So, to include, I think we should attempt the functional jaw orthopedic even in unfavorable cases. Some of the systemic review again. This study concludes the mandibular growth and the functional therapy in the clinical insignificance. We will take a look at the case which might take you a considerable conclusion in this systematic way. Still, the growth of the mandible is a debatable one. This is the 15 years old guy, respond to our clinic with the chief complaint of the forwardly placed the upper incisor. Incompetent lip and the mental is was hyperactive and had a gold watching. Look at the chin. Interlabial gap is almost 6 to 8 mm. See the chin. See the nasolabial and mentolabial fold. On intraoral examination, class 2 molar relationship, moderate lower entry, upper and lower crowding, intermaxillary incisor, increase the overjet and completely deep bite. Cephalogram shows the proclination of upper incisor, CVMI stage 5. We had a very little to work on the growth. This is the preoperative OPG. See how the mesioangular third molar. This is the twin block appliance and the design. We added the two jack screw to expand the maxillary arch as it was a tapered one. Teeth were already rotated, crowded, and it was a procline. So to parallel expansion, I have added the two jack screw. This is the facial appearance immediately after the twin block therapy. The profile was straight, lips were competent, all the facial balance are established, the mentals are now relaxed, goal ball appearance is decent. This is the comparison before and after the twin block appliance. This is the pre and post TBS cephalogram comparison. This is how much we have able to grow the mandible length. The mandible growth was more than 2 millimeters. In the 2 millimeter increase in the mandibular length, we sufficiently applied the 60-degree visuoangular impacted mandibular third molar. See how the third molar is upright. See, there was the nose space and the visuoangular third molar. This is already upright. We were able to achieve the proper class 1 relationship, class 1 Cannon relationship, normal overseat and overbite. Though it was a crowded and the procline one. Overjet, overbite. We were able to achieve such a balanced, relaxed and straight soft tissue profile without extracting any bicuspid. Comparison of the lateral profile. Comparison of the cephalogram before and after. These are the OPG comparison before and after, and how the third molar is operated in the This is another Crocker study which concludes that all the functional appliances include the mandibular length. There were lots of contradiction in the literature. There is no advantage of incremental bite attachment. When there is a more than 50 millimeter of overjet, one should not attempt in a single advancement. In the plan of the incremental advancement should be given the priority. Preksha is a 12 years old patient visited our clinic with the chief complaint of the protruding teeth and incompetent lip. She has a history of the lip biting long before. Severe crowding in the lower angle class 2 molar relationship, increase the overjet of the 20 millimeter, and the deep bite. Upper first premolar and the second molar were in a telescopic relation with the lower arch. This is the preoperative cephalogram. Despite all her chronological age, that is 12 years, CVMI stage was almost 6. CVMI, vertical. OPG. So we started with the twin block appliance having a two-stage activation, and after the correction of the functional appliance, orthopedic, we have decided to remove the bicuspids to unravel the crowding lower as well as to retract the upper anterior teeth. These are the outline design. The mandibular advancement was done in the two-phase. This is the outline at the time of delivery. Immediately after the correction of the first stage, we have advanced the bite by adding the cold cure acrylic in the chair side tap. This is the stage where we perform the incremental advancement by adding the cold cure in the lower appliance. This is the cephalogram after the triangular therapy. OPK. This is the profile we achieve after the pre-block appliance of the 12 month. Lip trap, interlabial gap is reduced, increase the profile, increase the smile, and the convexity of the face is reduced. Look at the comparison of the pre and post TBS cephalogram. This is the comparison of the before and after the pre-block appliance. See how the relaxed lips, close the lip, smile is improved, convexity is reduced. These are the comparison pre, immediately after twin block, and what we achieved at the end of the twin block. This is the current stage of the cephalogram. Exsection space is almost closed in upper as well as the lower overjet overbite is achieved, and it is on the verge of the decoding. These are the pre, post TB and the current stage of the comparison. This is one of the simplest cases by the beginners who attempt with the pre-block appliance. On extraoral examination, we have seen slightly convex profile, incomplete lip, and the deep nasolabial fold. Full unit class 2 molar relationship, class 2 canine relation also, moderate deep bite, and the mild imbrication in the upper as well as the lower. If you see the cephalogram, CVMI stage 4, and the mandible are not more than a mid-5 degrees, though I have tried to advance the mandible. These are the OPG. These are the applied design having a lateral brow from canine to canine. Interdental class are given in the lower interdentally as well as the Adams class is given into the upper first part. These are the appliance in the mouth. After the twin block appliance of 10 months of the period, this lip are competent, smile is perfectly balanced, and the profile is straight and pleasing. These are the intraoral picture. Angle class 1 moral relationship are established. Class 1 canine relation is also established. Perfect interdesiccation is achieved. The remaining space in the upper imbrication can easily fix with the aligner or fixed mechanotherapy. These are what the chef says after the twin block applies. OPG. These are the comparisons before and after. Now I would like to highlight some of the cases having it last time. Reverse stream block, Rushabh Parekh. The simple case of the reverse stream block, he was 11 years old when he reported, and the chief complaint was a protruding the lower jaw. On intraoral examination, maxilla was constricted, bilateral crossbite, anterior crossbite is also mixed dentition having an uninterrupted premolars. These are the OPG. Look at the shape. SNA was 80 degree, SNB was 86.9, ANB was minus 6.9, and SNB was 8.3. So there was a problem of the maxilla as well as midface. These are the data. This is the appliance we designed, the lipid on the maxillary appliance to get the Frankel-like soft tissue fed response. Labial bow in the lower anterior and Adams class on the upper and the lower first permanent molar in the given. As soon as we achieve the edge to edge bite, I have reduced the upper anterior bite block from the anterior lip, keeping the leading edge in contact. See, reverse bite is a jump. Profile is A. Secondly, as we remove the anterior bite, tongue will be maybe a major role to correct the upper incisor in retrocline cases. So we achieve the positive overbite, profile is improved, and we kept for observation without any applies. The pre-treatment and post-treatment fixed comparison, physiologically the occlusal is established without any fixed mechanotherapy or without any of the removable applies. Look at the molar relationship, overjet overbite, and the interdigitation in the costal segment. Post-deboning profile. This is a post-treatment deboning after deboning cephalogram. We are able to decrease the ANB from -7 to -2.6. This is class 2 correction could be due to the backward rotation of the mandible, increase the maxillary length, and the restaking the mandibular growth. OPG before and after. Profile before treatment, at the end of the treatment after the surgery. But if the surgical correction is required, the quantum of the surgery can be reduced. One more case having a class 3, Sapna Patel, 14 years old girl, visited our clinic for the chief complaint of the lower teeth display during the smile. On a pre-treatment cephalogram, CVMI stage was 4, frank maxillary deficiency is visible, pre-treatment OPG, intraoral examination, crowding in the upper arch, lower incisor of the retrocline, super class 1 molar relationship. Since the patient had able to bring the incisor edge to edge, we have started the reverse stream block applies. See, there is no space for the canine. And when it is a class 3, we cannot afford the extraction of the premolar in the upper arch. So, how to manage? was the upline design. Adams class on the upper premolar and the first molar and the central incisor. Two jet screws are placed to create the served space to distalize the molar and proclaim the upper anterior. See, after the reverse split block applies, look at how the space is created. How the space is created by it. And by the jump, these two is we achieve the end-to-end relationship. This was the before and after, and what we achieve the inner space where accommodate the canine. Fixed mechanotherapy is started, and this is how it went. Canine is perfectly seated, crowding is the relief, overjet, bite is maintained. And look at, this is the post-treatment intraoral picture. Proper class 1 molar relationship, canine, incisor and perfectly interdigitation is achieved. These are the comparison before and after. Look at how the canine is perfectly placed in the upper arch. And still the molar are in a class 1, rather it was a super class 1 before the treatment. These are the OPG before and after. And this is OPG before and after. Look at the third molar, which was more or less upright when we started the treatment. But at the end of the treatment, it became visual. That means that there is some restrictive force in the mandible. These are the comparison of the picture before and after. And this is the 10 years follow-up. Look at the smiles. Look at the lateral profile. See how the occlusion is sustained even after 10 years without fixed appliance. One more case is having a severe class 3. 10 years old boy presented with the chief complaint of the protruding lower jaw. Look at the intraoral picture. Severe underbite, reverse bite, and see how the upper incisor arch impinging the lower alveolar bone in the lingual aspect. And there was a more than 100% of the deep bite. This is the cephalogram treatment. These are some data. SN was 72.6, SNB was 82.1, and ANB was minus 9.5. If the patient was able to bite age to age, I have attempted to correct the class rate with the twin block appliance. This was the applied design. I have given the upper lip pad for Frankel 3 appliance. And I have also incorporated the teeth in the lower appliance in an edentulous space so that the tongue and proprioceptive mechanism will be more effective. This is the appliance, how put into the oral cavity. Upper anterior twin block was relieved from the upper anterior so that the tongue pressure will be an effective one. These are the pre and post after the twin block. How the mandible is in the control and mid face is also improved. Look at how the bite is jumped. I have removed the appliance and or just under the observation so that the eruption of the canine and premolar will take place, and I keep under observation that again the bite will not come forward. Secondly, there should not be any mobility from the incisor. And to close the point, I have built elastic modules in the posterior segment interdentally and see how the interdigitation will created. This is how the enteroposterior correction will take place. Fixed mechanotherapy is given to operate the lower incisor and to operate the canine, and applies cisplatin. Look at how the interdigitation will applies over jet overbiotic villi and the canine in class 1 relationship. These are the before and after occlusal view. Look at how the facial comparison before treatment, after twin block applies, and after the fixed mechanotherapy. These are how the improvement will take place from the profile class 3 to class 5. And this is the comparison of the before treatment, after twin block, and what we achieved after the fixed mechanotherapy. These are the cephalometric. 5 years follow-up. Look at the profile. Still it maintained without any fixed appliance. Sir, do you permit me for a few minutes? Should I conclude my? Thank you for hearing me patiently. If any of you interested in the learning the more about the functional therapy, we would have a full day pre-conference course in the upcoming PG convention in Delhi. If any of the PG or HOD are interested in doing the study in the twin block appliance, we are welcome to our office in Gujarat. If any want to discuss the twin block cases, feel free to send me on my email. Thank you all.
Thank you, sir. We truly appreciate your time and valuable